been a couple of weeks since we've been live, and I just looked at the calendar and the sun is shining, and I thought, I don't know about you guys, but it's been the fastest first of the year and also the longest winter. I don't, Dr. Robley, do you have the same experience?
I feel like just that's a general truism as I get older that things go fast and slow simultaneously. So
I,
yes.
you know what? You know what? That's I'm also mindful that I'm getting older too. So,
Yeah.
well, welcome everyone. I'm really excited about this conversation today. We're going to talk about migraine and ER visits, and we get patients asking us a lot, like when do you go to the ER? When is too long to go? How often should I go? When is it an emergency? So we're going to dive into that today. Dr. Robley, will you just give a quick introduction of your practice?
Yeah, happy to. So, my name is Jennifer Robblee. I'm a headache neurologist, and I practice in Phoenix, Arizona at the Barrow Neurological Institute. So, basically, my all day, every day at work is dealing with people who have headache that are just extremely disabling.
Yeah, I think that obviously makes you more than qualified to be here. So thank you for giving us a few minutes. We know that patients are probably thinking, I wanted that hour with her, and they are taking it. So thank you for joining us. But talk to us a little bit about what are the most common reasons patients living with migraine would go to the ER?
Sure. So, I mean, I think the first obvious one is you've got a severe migraine attack. You've tried your typical things and it's not working, and you're looking for some help.
Yeah.
Obviously, there are sometimes some other features of your attack. Like, let's say you're having a lot of nausea, vomiting, and you're just not even able to keep your medications, food, hydration down. So, those are another reason. Uh, Another common reason I see is something scary about the attack. There's something different. It came on more sudden than usual. It's more severe than usual. Maybe it feels different. Maybe you've got an aura and something about those aura symptoms are really scary. So, basically something's changed.
Yeah.
And then getting a little bit into the first one, but just calling it out more specifically, is status migrainosis. So, status migrainosis is when you have a migraine attack that's gone on for more than 72 hours. It's a severe presentation. So, one of the reasons people end up in the emergency room is they've gotten into this complication of status migrainosis. And then on the more chronic end of things, we have patients who are very refractory to all treatments. And sometimes, even though it's not necessarily anything's changed that day, it's just been this long slog of day after day, nothing helping, week after week, month after month, year after year. And sometimes they just get frustrated and come just, is there something that they can give me to help in the moment?
Yeah.
Um, and then the other thing that I sometimes see is they're worried. It's not necessarily anything's changed, but maybe this is something that's been progressing or worsening over time. And they're scared that there's something going on, like a brain tumor, and they're hoping they can get an MRI to just reassure themselves that there's nothing dangerous happening.
Yeah, yeah, that makes sense. I can actually see that picture when you're painting it of the patient who has been in bed for a couple of days, lots of pain and
Mhm.
other symptoms, and they're going, I can't take it anymore. I can't take it anymore. You said something about 72 hours and people having status. Can you talk a little bit about that? Like, what does that just mean head pain for 72 hours, or can that be any debilitating symptoms for 72 hours?
So in headache, we use what's called the ICHD. So that's the International Classification of Headache Disorders. It's currently in its third edition. So there's diagnostic criteria in there that help us diagnose a headache. Um, and it's not clear, which is one of my current issues with how status is actually diagnosed. Um, it is presumably talking about the headache phase, but migraine can have several different phases. So you can have the prodrome or premonitory phase, which could be hours to days. But a third of people have the aura phase, which are reversible neurological symptoms. Most, but not all, during an attack will have the headache phase, and then some people have the postdrome, which is colloquially called the migraine hangover. And so, how all of those phases fit in are not clear, but the assumption is we're talking about the headache phase.
Yeah, yeah. Okay. That's a really great point. If you already have a migraine diagnosis, you talked about some of those scary things that somebody's like, oh gosh, and we certainly want anyone who's watching when you're in fear, go. Like we don't want someone to come up and they've
Yes.
had a stroke or something else is happening and they hear this and say, oh, they said I didn't have to go. But let's put that out there for my own,
Yes.
right, for both of our own sanity. But talk about when is it okay to go? Is it I mean, talk a little bit about when a
Yeah,
patient is struggling, and I know that's kind of a open-ended question, but when does
sure.
someone feel like it's okay to go to the ER or
Yeah,
ED?
well, kind of jumping off what you said, if you're worried, if there's something that's scaring you, something is different, especially if you can't get into your doctor, can get assessed quickly. Asking something over a portal, we can't assess you. I can't look at the back of your eyes. I can't, check to make sure there's nothing that I'm worried about. So the safest advice is always going to be to go to the emergency room in that setting. And obviously the goal is to not have you do that. And most of the time it is going to be migraine and you are okay. But just, safest
Yeah.
is if you're worried and you can't have it shown otherwise, then that is the best thing to do. Now, if you are having a first time, especially aura, it can look very similar to a stroke, or if it is a completely different aura than what you've experienced before, safest is go to the emergency room in that setting. Now, if you have recurrent stereotype, i.e., it's basically always the same, and it's another event similar to ones you've had many times in the past, then in all likelihood, unless you've been counseled different, you probably don't need to go to the emergency room in that setting. A stroke is going to have already happened if you've had multiple of these events, if it was going to be a stroke. So that likely can be managed as an outpatient, but know that there are always exceptions to that. And so that's just a general teaching and not an absolute 100% rule.
Yeah. Yeah.
Um, Another thing is if you have a headache that comes on just suddenly, it's called a thunderclap headache. So if someone were to hit you in the back of the head with a hammer and just out of the blue, you've got this insane 10 out of 10 worst pain you could possibly imagine in your life that comes on over seconds, that's a reason to go to the emergency room because that can be bleeding in the brain or something else. Also, if your headaches are newly positional. So if you normally, when you have a migraine attack, you're going to want to lie down. You don't feel great. You're going to feel better lying down and resting. But if your headache essentially goes away or nearly goes away when you lie down, but then when you stand up, it's worse, that's consistent with what we call a low pressure headache. That can be something like a CSF leak. That needs further workup. And that can sometimes come on suddenly like a thunderclap. So again, all the more reason in that setting to get assessed urgently. And then if you have status migrainosis and you aren't able to get a hold of the person managing you, I personally think that's a reasonable time to go to the emergency room. And we can talk more about how we can try to make it so you don't have to. But if you don't already have a plan in place and easy access to a treatment, the emergency room is an okay place to go.
Let's jump right into that because I'm actually taking notes and watching the chat in case people have questions. So if people are watching and there is something that comes up, please feel free to put it in. We'll answer it later if we can't get to it now. Talk about if you're someone who is having chronic pain. It's 72 hours. You're constantly trying to figure out, what kind of preventive things should people be thinking about,
Yeah.
especially if they're maybe have had headaches years ago and didn't realize there's new medications out. Talk a little
Mhm.
bit about prevention.
Yeah. Well, first thing, reminder that your migraine treatments acutely, they're going to work best early in the attack. If you take them late into the attack, that whole pattern that happens in the brain is going to get reinforced, and it's really hard to break that cycle. So while they might work early, your treatments may not work as reliably late. And then that might be when you get into one of these longer attacks. So first off, just treat early. I know people often are like, but I only have so many pills, end up hoarding them. But I do find some people, if you treat early, you're less likely to have that headache come back later that day or the next day. So just treat it, and don't kind of take your gentle stuff first, knowing that you're end up taking your like harder stuff later. Like jump right to the stuff that works, because that's when it's going to work best. That first half an hour of the headache is like golden, and we even have some evidence that medications like Robblee, that can even work in your warning symptoms, your prodrome phase. So you can take that even earlier. And if you're having headaches frequently, like approximately weekly, you should be talking to your physician about whether or not you should be on a preventive treatment. Because again, preventive treatments, they're going to make these attacks less likely, and it's more likely that your rescue medications are going to work. So that's how we kind of want to prevent this happening. But let's say you're already in the middle of it, still try all your home treatments. But we do have some evidence for what you can do if you come to the emergency room. We have no guidelines on what to do if your home medications didn't work and what to do to treat you at home. we have lots of things that we can pull from the evidence that we can sort of infer what we might do, but there is no guidance. You're going to see massive variation between different clinicians of what we do. If you go to the emergency room, we now do have some guidelines that have been recently published, and the best evidence is for two things. The first is for what's called a greater occipital nerve block, and that's where we use a local anesthetic, which is a numbing medication like lidocaine or bupivacaine. And that's, if you go to your doctor and they freeze your jaw to do a procedure, they're basically doing a nerve block. But here we're talking about one that targets the back of your head where your occipital nerve is. So that's one treatment that has really good evidence. The other is a medication that's called prochlorperazine. You might have heard it also called compazine. That's its whole trade name. So it's an intravenous medication that blocks a chemical in the brain called dopamine. And that medication also has really good evidence. If you look it up, it was originally made for an antipsychotic. It's also meant for nausea, but it actually helps the headache phase as well. But it can make you feel really sleepy. And then some people actually can feel sort of jittery or restless on it. We can give you treatment to help with that, but those are two very common symptoms that we see with it. And there are some other potential risks. So you want to make sure that you've been well educated on what you're choosing here. But those would be two of the best treatments that we have. And there's also some good evidence that dexamethasone given intravenously can help prevent the headache from coming back. Might also help in the moment, but the evidence is better that it helps it from coming back. So those are some of the best things we can offer. And there's lots of other things in the guidelines as well, but those are some of the higher ones.
What else should they be worried about? I know we've had patients who say that they get really nauseous with migraine attacks, and so then they're going to the hospital because they're dehydrating. And
Yeah.
are there other symptoms? Are there other things such as that someone needs to pay close attention to?
So, I mean, definitely if you're having a lot of nausea and especially vomiting with your attacks, and that can make treatment at home harder. Another thing that can happen is gastroparesis, and that's basically the stomach is not moving and emptying as well. And so that can lead to your medications not getting as well absorbed. And so in those cases, we want to make sure that you have options at home, that you don't have to rely on a pill that you need to swallow. So that might be where you're using a melting pill. So those are called like ODT, orally dissolving tablets, and nasal spray, and injectable medication. So those are some great options. And then knowing that if you tend to be nauseous, having some sort of medication to help with the nausea. So a classic one at home is ondansetron, which you might be calling Zofran. And that can come as a pill that melts. And that actually comes as an injection for home. So if you are ever comfortable and you have a physician who's comfortable, you can be taught how to do that at home in these really bad situations. And the prochlorperazine medication that I was talking about, there's multiple medications in this category. And they actually come as pills as well. So you could have that for home use. And as I mentioned, it doesn't just help with the nausea. That one can also help with the headache as well. So there are some really good options to help with managing that. But again, if you're not getting food, not getting hydration down, that might be a reason to go to the emergency room or an urgent care.
Yeah, yeah. That's a great point about urgent care, because we have people that also say they'll go there and end up in the ER because they get nervous about whether it could be something else happening.
Yeah.
And so they end up in the ER anyway. Is it always customary that if your head pain is really bad, that you should go straight to the ER, or any advice about that, urgent care versus ER, and not to compare their ability?
It's a hard one. Yeah, it's a hard one. And it's probably going to depend on what urgent care you go to and how comfortable that provider is with managing headache. The reality is if there is nothing scary going on, urgent care probably is the better place to manage a headache in that sort of setting. But if there's any concern for like that thunderclap, positional type headache where we need to do a more urgent workup, that definitely needs to go to the emergency room.
Yeah, that makes sense. That makes sense. What about someone who finds themselves constantly having to do ER visits? They're seeing a headache specialist. We have someone that's openly speaking about this in the chat right now.
Yeah.
What do you do if nothing's working and you're just frustrated?
Yeah, so it's a tough scenario. And I mean, a large chunk of the patients that I see are going to be at that more extreme end. I don't see, the typical migraine patient. I see the patients who nothing works for. And so this is my personal approach. It's not necessarily evidence-based. I've inferred from the evidence and I've kind of refined what I've done over time. But what I usually do is give my patients different, what I like to say, tools in their toolbox. So you might have, say, your sumatriptan at home, and it, gets your headache gone, let's say 80% of the time, but that 20% of the time it doesn't work even when you've repeated it. So in that patient, I would make sure that they have a backup for that, 20% of the time. So we come up with something like, let's say they know if they go to the emergency room, that prochlorperazine works really well for them. Well, maybe I'll make sure they have some prochlorperazine at home to use. And maybe if they find it makes them really sleepy, so they don't really want to use it for all their attacks. So we don't want to just jump right to that in that setting. But in the setting where, well, I was going to end up in the emergency room anyway, they might feel comfortable using that, even though they know that one, they always feel really sleepy and tired from it, so they end up having to nap. But at least it's keeping them home and out of the emergency room. Mm-hmm. So that might be an example of something that we could do. Or I might have patients where, they end up in these really long status migrainosus attacks. And while the definition is more than 3 days, I've seen it go on for weeks and months. Mm-hmm. And they're in the criteria, there is no max duration. So I don't know, if you've had the same attack for 3 years, is that still status migrainosus? We don't actually know. But some people, for instance, respond really well to steroids in that setting. And so in that patient, perhaps we would try a short course of steroids. The evidence is not perfect. We don't really know for sure. But if the experience that I have is that patient responds well to them and they tolerate it, and I've counseled them on the risks, then making sure that they have access to steroid for when they get into those occasional attacks. For other patients, it's really the intravenous medications that work best. And so there are outpatient infusion clinics that can give you a lot of the same things that you would get in the emergency room. And some of those are ones that you could call even same day or at least the day before and get an appointment booked. And so making it so you can go and have, a scheduled appointment in an infusion clinic where it's a much nicer, calmer setting than the emergency room. That's another option. So there's a lot of things like that that we can do. I have some patients where we have like multiple steps. So you do this at the start of your attack if it's a mild one. If you can tell this is going to be one of your bad ones, this is what you do. Okay, if that hasn't worked and you've gotten to, like halfway through the day, this is what you do. If you're into the next day, this is what you do. If that still hasn't worked and you're getting into status migrainosus, this is what you do. So for each patient, it's kind of what I say, it's like your own recipe. And I really wish we had better guidelines for this. I think this is an area that we're lacking. It's a major gap in the literature. And so you're going to see just such variation there. And of course, the other thing is making sure that you've got good preventive medications on board. A good teaching, and I see this as an issue that happens often, is if your rescue medication is not getting rid of your attack within 1 to 2 hours, and you're not able to get back to normal function, and you don't feel like you can rely on your treatment, you do not have a good enough rescue treatment. Now, I have, again, severe refractory patients where it doesn't matter what I try. That's never true for them with all the things we keep trying, but we keep trying. But if you are someone who medications otherwise are working well, let's say you used to have attacks that were 3 days and now, you feel better within 24 hours, that medication is not working. That's not good enough.
Yeah.
You go back and say, hey, it's improving things, but I'm still struggling for a day. Your goal should be you get your headache gone in 1 to 2 hours.
I think what you just said is huge. It's something that has stuck with me in my first year of working with AMF is setting that bar of what's good enough. Because I think we often hear people say, well, I've gotten where I only have, 4 headache days a week or what it's
no,
good
that's enough. Not good enough. That's great that it's improved, but it's not good enough.
Yes.
Yeah, we want to be perfectionists here. I don't think we give enough credit to our whole patient population in migraine. You guys are often labeled as complainers and just like drug seekers, but my experience is such the opposite. I'll ask someone how often they're having their headaches. They'll be like, 8 days a month. I'll be like, so what's happening those other 22 days? Oh, I just got my normal headache. So you have a headache every day then. You don't have a headache 8 days per month. Yeah, but it's just a 5 out of 10. Guys, that's not normal. That's not normal. That's not good enough. You have a headache every day then. And actually you have a migraine attack every day. A 5 out of 10 is probably a migraine attack. So you guys undersell how much these are affecting you. And for a lot of you, it is just so normal to have a headache that you've just accepted that this is just the way it is.
Yeah.
A normal person should have zero head pain. That is normal.
Yeah.
So that should be our goal. We may not be able to get there, but it doesn't mean we can't try.
Does that also mean being aware of the other symptoms too you may be having?
Absolutely, yeah.
Yeah.
Yeah. So I mean, you shouldn't be nauseous all the time. You shouldn't feel, slow and just like cognitively out of it. And if you have a headache all the time, yeah, your brain's using up its energy to make you have your headache.
Yeah.
Of course, you're going to feel cognitively slowed, but if we can maybe get you better, that might improve too. So these things aren't normal. You shouldn't have to put up with them. Yes, there are people who, as a headache neurologist, I'm going to see who are refractory to treatment. But as long as you want to keep trying, we should keep trying and find something that works for you. And the majority of you, there is going to be something that works for you.
I mean, how hopeful is that? I mean, I know we've got some people commenting in the chat, and and I know the specific person she's posting this live, so I can say it. She's going to a great doctor. What do you do? And we won't specifically refer to this doctor because I'm not like we won't talk about this one in particular. But what if someone's going to a doctor and they're not getting the results of what you're telling right now, and their doctor is saying, yeah, this is they're not offering the preventive, they're not offering other things. What do you do?
I mean, I think it's a hard one because there are not enough headache neurologists to help all the people who have migraine. I think you should at least have someone who does not make you feel bad. Migraine is not your fault. So if you have someone who's making you feel bad about what's happening, I think you should find someone else. Your doctor should never tell you there's nothing left. I've never told my patients that there is nothing left. If they're telling you that, then you need to find someone who you feel supported by. If they tell you that your headaches are exclusively from your weight or because you're depressed or you're stressed, that's not correct. Could those things be impacting your headache? Absolutely. But there is no such thing as a headache from being overweight. And I've yet to see a headache be purely due to a mood disorder. They definitely have an impact, but it's not the cause of your headache. They are triggers or they are things that are impacting your headache. So I think if you're seeing that, that's not good enough. If you have someone who's jumping immediately to opioids for headache, that's not the right choice. We have better things that are safer and that actually work better. Evidence actually shows, for instance, prochlorperazine works better than opioids. It actually beat it out very, very, very clearly in studies. So you want evidence-based treatment. Yeah, I mean, there's so many things, but the hard part is most people haven't been educated enough on headaches. So if you're not seeing a headache specialist, they just may not have the education and experience. So they're doing the best they can. And so that's where having a group like AMF is amazing because you do have good resources. You can bring some of the teachings that you have here back to your clinician and they should be receptive. I mean, I am an expert in headache. This is what I do, but my patients will bring me things that they're interested in and we'll have an interactive discussion about if I think it's a reasonable thing to consider. If I don't think it's reasonable, I'll give my reasons. But if it's a relatively safe, benign treatment and someone really wants to try it, I'm okay with that. And I'm also okay if they find some evidence that they don't think what I'm suggesting is a good idea, and then we can talk through that. Your doctor should never be offended that you're asking for a suggestion.
Yeah.
You're allowed to do that. It's your body.
Yeah. Yeah, that's such a great point. I was actually thinking we've been talking about having printables for people to take to their doctors, and I was thinking when you were going through the different medication options, I was like, we need to have things available for patients to be able to say, here's something I heard about that we're not trying or that we need to try. And
Yeah.
I encourage people to take that. And if you're one of the things I've heard that, and I love that you said as well, is if your doctor is kind of like, I'm not familiar with that, and kind of shrugs it off, they're going on to the next patient. Not that they don't care, but they're going to see the next patient. You almost need an advocate with you sometimes to say, no, actually, his or her pain is, she says it's at a 10, 5 days a week. Like I don't know if you find that, but having an advocate with you can also help.
Yes, it can definitely help. Some patients are really great at being their own advocate, and sometimes it's a loved one who's the advocate for them. You do want to make sure, though, that your advocate doesn't push things the wrong direction, because I have seen that happen, because
Fair.
sometimes they're really distressed because they want to help you. And I find that it can actually sometimes be a little bit harmful. So you both can actually end up then having a lot of anxiety. And if you have someone who's trying to be your advocate, but they're more anxious than you, it can actually make you feel more anxious, and anxiety is not good for pain. So we do want to still have it be that you then have some sort of support, and take note of, how your advocate's helping you. If they're making you feel more anxious and worse about it, have a little chat with them about it, because it's well-intentioned. They're doing it out of love, and they feel helpless. But I do see that sometimes, and I can see it make the situation be worse. But I do think having an advocate is great. And if you have your family and loved ones not understanding what you're going through, and they're the opposite of an advocate, they think you're kind of exaggerating or making things up, maybe bring them with you to the appointment so you guys can chat through and help them understand, because that's also really awful. If you have someone at home and they're kind of just doing the exact opposite of validating you, and you're feeling almost gaslit, like, have them come to the appointment. Like, that's the type of thing where I can sit down and answer their questions and help them understand that this is something real. You're not making it up. They might not be able to see what you're experiencing, but this is something legitimate. So both ends of the spectrum can be unhelpful, but having that sort of really good advocate is incredible and so important for people. So you feel like you have that support.
I think, pardon me, I think that's a great point, because you could have a partner or spouse who's like, it's not that bad, because the let's say we'll use the wife for example, is doing dishes and still cooking and cleaning and going to work, and they're like, you don't seem that bad, and you're like, I didn't tell you how bad it was, and
That
you don't
means
want
you
it to
have
go
good
into
coping strategies, or you're pushing through your pain.
Yes. So you're right. That's a really great point to make sure the person there is truly advocating. I want to bring up one more point, and this is getting off the ER topic just a hair. But one of the things is, if you're going to a general practitioner and you're going for your annual physical, and that's when you get your medication, talk a little bit about, like, that bleeds into all of this, right? Because we have people say to us, well, I have high blood pressure. I think I have migraine, and I think I have this. And so migraine gets kind of smushed in there, and we barely talk about it. Any advice on prepping for that appointment that could possibly help make that a little more productive?
Yeah, I mean, come with some really easy, ready answers. So that might be a really great time to have done a headache diary for a few months. So you could come in and say, I have a headache this many days per month. This many of them are bad. I'm relying on a rescue medication this many days. And when I take my rescue medication, it's taking me, 8 to 10 hours before I can get rid of my headache. And what I've learned is that it should be only taking about 1 to 2 hours. So I think I need some better treatment. Is that something I should be doing with you, or is there someone that you can refer me to help?
I love that.
And then you're giving them the info in the quick way that honestly their schedule might be set up to only be able to handle. So you're being respectful of what they need to get through when you have a long list of things you have to do, but you're getting the relevant info out. So that's what they need to know. How often the headaches are, how often the bad ones are, what are you using, how often are you using it, and how quickly does it work? For me, that every single follow-up, if I've done it in my optimal, that's the information that I should at the very least have, because that's how I decide what treatment changes we should make. So if you can get those pieces, those are really helpful.
I love that, because that goes back to having the right advocate. You don't want to wait till that appointment to be like, no, you have them like 3 days a week.
And talk to your advocate, because yes, they will have to be like, no, it's not weekly. It's more like 2 to 3 times a week.
And you've got 10 minutes. You're like, this isn't the time to sit and discuss what agree on like what's happening.
That's where a headache diary is really helpful. And I know some of those headache diaries are really overwhelming. The one that I recommend to people is the stoplight diary. If your headache has you in bed, non-functional, that's a red day. If you can push through the pain, but it's harder, that's a yellow day. If you have a headache in the background, but you can totally ignore it, that's a green day. And I like to differentiate. If you are truly crystal clear, 100%, no pain, you feel great, you are basically completely at a normal, then you can leave the day blank. But if there's even a 1 out of 10, that's still a green day.
Yeah.
And if you can come and bring that info, that for me is just golden. That really helps me be able to see where things are at and also track things over time. And then it gets you away from having to be like, I don't know, is this an 8, a 7? I'm awful at giving a number as well, even though we still ask it. So at least that
Right.
gives us more of the function, which is honestly what we care about more.
Yeah, that's so well said. Well, Dr. Robley, thank you so much. I kept watching my time going, oh, I got to stop, but I got one more question. Thank you, thank you. We'll have to have you back on. Thank you for those who interacted in the chat and for those who may be sending in questions. We're always happy to continue having a conversation, but thank you, thank you. Thank you for giving up 30 minutes. I'm sorry to whatever patient could have had that time slot, but hopefully this was helpful to a lot of patients today. So thank you. Thank you for what you're doing and for caring so much about our patients.
Absolutely. Guys, just remember that there's hope. Even though we don't have these perfect answers, there are people like myself who are really working on trying to find these answers, and we really do care. So you have a lot of people in your court. Okay.
I love that. I love that. Thank you. And I hope everyone has a great day and it really has a crystal clear day. That's what we're shooting
Yes.
for, right?